Hi everyone, welcome to the revision lecture on psychotic disorders. My name's Emma. Thanks for watching this and hopefully good luck with all of your exams. Here's my email on the screen. Please reach out if you have any questions or you can reach out on Facebook. And I'd like to thank William Upjohn, the previous PsySOM revision lecturer. I've pulled some content from his slides as they're really useful. So the things we're going to cover today on your matrix is the psychotic disorders. This is schizophrenia, substance-induced psychosis, schizoaffective disorder, schizophreniform disorder, brief psychotic disorder, and delusional disorder, and psychosis secondary to a medical condition. I think it's really important first to define what is psychosis. So psychosis isn't a diagnosis. It's a state of mind. It's almost like a syndrome of that a person can be in, and it can be a feature of many disorders. So it's a state of mind that impairs a person's ability to determine what is real and what is unreal. It's a loss of contact with reality. And it has 5 defining features, and hopefully by now you guys are well across these features. So it's delusions, hallucinations, disorganized thought or speech, disorganized behavior, and negative symptoms. We'll touch more on what those are. So delusions are a strongly held false belief that are not typical of a person's cultural or religious background. There are many different types of delusions. Hallucinations are a sensory experience that a person has that is not actually present, or there's no external stimuli to cause that sense. It can occur in any of the 5 senses. So you can have auditory hallucinations, you can have visual hallucinations, you can have tactile hallucinations, so touch, you can have gustatory hallucinations, so taste, and you can have olfactory hallucinations as well. Disorganized thought, for the duration of this PowerPoint or this presentation, I'll be using the disorganized thought and disorganized speech interchangeably because you can't really go into someone's mind and see what they're thinking. Disorganized thought is reflected in how the person speaks or expresses language or writes. So often it is very often mainly that with their speech that we can get insight into what they're thinking. And disorganized behavior, so bizarre or unusual behaviors that are not usual for the person or the context that they're in. This is important because if the person has disorganized thought and they don't want to speak to you and they're not expressing language in any way, it can often also just manifest into disorganized behavior. And then we've got negative symptoms, and negative means something that's usually should be there and it's been taken away. And we'll talk more on that as well. So let's talk about delusions. As we said, it's a strongly held false belief, not typical for that person's cultural or religious context. So strongly held means that it's really hard to convince the person otherwise. Delusions can be further categorized based on plausibility. So they can be bizarre, so something impossible, such as a person thinks that someone else has been replaced or there's been replaced by a lizard and the lizard is wearing the person's skin. That's, I would say, pretty impossible. Or they can be non-bizarre. So this could be believing that one's spouse is cheating on them. It could be true. So there are different themes of delusion. So there's persecutory, believing one's being persecuted or targeted by someone. There's grandiose delusions, so an inflated sense of self. This is commonly seen in mania. Erotomanic delusion, sorry, this is on the theme of love, believing that a famous singer is in love with them, etc. There's somatic delusions. So typical one is believing one's sinuses are infected with worms. Delusions of reference. So believing that things playing on the radio or the TV or on the newspapers are somehow directed specifically towards that person. Delusions of control. This can be thinking that one's thoughts or actions are being controlled by another person or other objects. And then sometimes you'll see the word autonomous. So this is like a delusion that just comes out of nowhere. It occurs suddenly, and the person is completely convinced this is true. So it could be just one day someone out of the blue suddenly believes that they are part of the royal family, and it's just like that. They suddenly like that, and then they just believe it. That's what autonomous means. So we sometimes in some past exams, specific delusional syndromes have come up. They're pretty low yield, but they're here as just for your reference. So I'll just go through them briefly. So we have Capgras believing that an imposter has replaced a familiar person, intermetamorphosis, believing that an unfamiliar and familiar persons are identical because of a shared characteristics by the beliefs. Subjective doubles, believing that there is a double of oneself in the world who is acting in such ways that damages reputation. There's Fagoli's, believing an unfamiliar person is disguised as a familiar person. There's delusional parasitosis, believing one has been infected with insects, can be paired with tactile hallucinations such as like itching or formication, that's called, and it's just the feeling of things crawling over your skin. It's common in stimulant-induced psychosis. There's Cotard's, it's a nihilistic delusion. So believing one is deceased, that they're dead and they're actually dead and their body is rotting and they're just in their bodies, watching themselves die. This is seen in depression with psychotic features. And then there's Ortello's syndrome, believing that it's an erotomanic delusion. It's believing that one spouse is cheating despite inextricable evidence proving the contrary. Let's talk about hallucinations now. So as we said before, it's a wakeful sensory experience that is not real. There's no external stimuli. It's vivid and clear. It's not under voluntary control, and it can involve any sensory modality. So it can be auditory, and auditory can be further classified into speech or sounds. If it's speech, it can be command or commentary, and it's the most common type of hallucination. We've got visual, and visual is not as common, and it's more so seen in deliriums than a psychotic disorder. Olfactory is one that you don't think about, but it does happen. I've seen a boy who complained that his bedroom smelled like poop and that he was convinced that there was poo somewhere in his bed because he was smelling these unpleasant smells. As we mentioned before, there can be tactile hallucination. So this could include formication. It's the sensation of bugs crawling over the skin. There can also be other tactile hallucinations as well. And then there can be gustatory, which is taste. Usually tastes that are strange or unpleasant. I've seen in epilepsy, and people report a metallic taste either before or after the seizure episode. So let's talk about disorganized thought now. Disorganized thought is, as we said before, reflected in disorganized speech and writing. You can't read someone's thoughts. So it's issues in the organization and expression of thoughts. And when we talk about thought, it takes us back to our mental state exam. So thought encompasses three things, so stream, form, and content. So hopefully by now you're quite familiar with this, but thought stream is the rate at which thoughts come into someone's head. So it can be increased, decreased, normal. At the extreme end of increased, you can have flight of ideas, and that's where thoughts are just rapidly flying into the person's head, and it's reflected in rapid speech, etc. It can be decreased when the extreme end of that is poverty of thought. They can just not, they often just say nothing, and they just don't think anything. And then we talk about form. So form is basically how the thought is formed, whether it's logical or not, whether it's cohesive or not. Does it make sense? Can you follow along? So again, you should probably know all of these by now, but we'll just briefly go through them. So thought form can be circumstantial. So it's an inability to answer a question without giving excessive unnecessary detail, but the person will always come back to the original point. And I like to think of it as when you talk to some elderly people, they just talk so much about so many random things, and is it in and of itself isn't necessarily pathological. Then we have tangentiality. It's they wander away from the point and they never come back to the point. So it's important to know the distinction between these two. Loosening of associations is illogical leaps of ideas, leaps from one idea to another. It's a feature of schizophrenia. It's you can The difference is in between loosening of associations and Knight's move is that you can still sort of sense how that person got from this idea to the next. So, for example, that notebook is blue. I like the ocean because it's blue. I really love swimming. You can see that how it's connected by the color blue, but it's not necessarily a logical leap from one idea to the other. Then there's flight of ideas that we talked about in stream as well. And then we have Knight's move. So there's no connection between thoughts. So the name Knight's move comes from how the knight or the horse from chess moves. It moves in an L shape. So there's sort of in the person's mind there is a link, but they didn't say the link, so it's like an L, and you don't quite see how it makes no sense to you how they got there. There's clang of association, so ideas set together because they rhyme. Word salad, so this is a really extreme form of disorganized thought. Where incoherent speech where words are strung together that make no sense. So the grammatical structure of the words of the sentence is lost. In thought content, there's also neologisms, making up new words, preservation, so repetition of ideas, or words, despite trying to change a topic, they're really fixed on that. Echolalia, repetition of the same words the interviewer says, and delusions. So delusions is the big one that we already talked about, but that is the big thing in thought content. Now let's talk about negative symptoms. So negative means the removal of something, the loss of something that usually should be there. And I like to remember with the 6 A's. So it can be blunted affect. So affect is what does blunted affect means? I like to understand it by saying you could say something really, really nice or really should invoke joy to someone, such as congratulations, you won $1,000, and they'll just be like, okay, that's okay, cool. And then you could say something really, really bad to that same person, like your grandma just died, and they'd have the same reaction. they lose that reactivity. That's what blunted affect means. Anhedonia, loss of the loss of finding joy in things. Avolition, so that's the loss of motivation. Alogia, so that's the loss of talking or talking less. Um, the uh, root word log means words. Apathy, so they lose the sense of like empathy or sympathy to others. They just don't really care about others. And asocial, they can be socially withdrawn. So these are your negative symptoms. Next, it's important to, well, it's not important to talk about the dopamine pathways, but I think it's good to help you understand, but you definitely don't need to memorize this. So the very basic theory of what psychosis and psychotic disorders are caused by is too much dopamine. And that's why the treatment is antipsychotics. What do antipsychotics do? They reduce dopamine. And we can think about it in terms of the pathways that involve dopamine. So we've got the mesolimbic pathway, where dopamine facilitates emotion and sleep. The mesocortical pathway, dopamine facilitates cognition, memory, decision making. Nigrostriatal, this one, dopamine facilitates movement planning. So it's your typical pathway in Parkinson's that it's famous for, where you get this rigidity and cogwheeling and shuffling gait and tremors from the lack of dopamine in this space. Then we've got tuberal infundibular pathway. This is relevant for milk production and sexual function. So the theory is that the mesolimbic, so this pathway, when it has too much dopamine, is responsible for the positive symptoms. So what do we mean by positive symptoms? We mean all the things that are there that have been added that shouldn't be there. So this includes your hallucinations, delusions, disorganized thought, speech, and behavior. And it's theorized that the mesocortical pathway is what causes the negative symptoms of, the what we talked about here. So blunted affect, anhedonia, abolition, etc. And then these two pathways are implicated when we do use antipsychotic treatment, because when antipsychotics, they take away dopamine and they reduce dopamine. And when dopamine is reduced here, you're going to get Parkinson-like symptoms. So this is what causes the extrapyramidal side effects. And it also antipsychotics do something here as well, and that's why it can cause increased prolactinemia and even lactation in some individuals. And here's a schematic just to show where everything is. Definitely don't need to know this. So, as we said before, psychosis isn't a diagnosis, it's a syndrome. And there are many different causes for psychosis. So, it can be caused by medical conditions. So, there's a few listed here. It can be substance induced. So, this can include illicit drugs or even medications. Steroids are really bad. And dopamine agonists, so medications used in Parkinson's as well. Because as what we talked about here, they're sort of increasing dopamine in this pathway, and then some of the dopamine will increase in this pathway as well. So that's why Parkinson's medication can cause psychosis. And then of course you've got your psychotic disorders. So this is the main things on your matrix, and mood disorders can cause psychosis as well. So both BPAD1 and depression. And I like to always reflect back to the pyramid of diagnoses. Whenever you're taking a psych history, you should always start from the top and think, is this something organic? And then work your way down to um, the the psychotic disorders, bipolar spectrum disorders, depressive disorders, and then all personality disorders at the bottom. So it's important to consider all of these in your diagnoses. All right, let's talk about schizophrenia. So, as we alluded to before, the symptoms of schizophrenia are split into sort of three categories. So, there's positive symptoms, the addition of something that shouldn't be there, so delusions, hallucinations, disorganized thought, speech, and behavior. There's your negative symptoms, so the removal of something that should be there. So, they have blunted affect, anhedonia, avolition, alogia, asocial apathy. And then you have cognitive symptoms. These are often more subtle and difficult to notice and can manifest as difficulties in learning and understanding and just um, function as well. And then it's important to talk about the phases of schizophrenia. So it's split into three phases. So prodromal, active, and residual. So in prodromal, the person has a noticeable decline in functioning, but however, the positive symptoms are often sub-threshold, so they're not overtly um, in psychosis. Negative symptoms may also be present at this time as well. So often during this phase, the person can sort of become reclusive, drop out of uni or school, stop going to work. It's things like that that we're talking about. Active is when the person is in psychosis and there's really severe positive symptoms of hallucinations, delusions, disorganized thought and speech and behavior. And then there's the residual after the active symptoms. So it's a slow return to baseline, the baseline of functioning, and the positive symptoms gradually go away. However, the negative symptoms may still persist. Now, this is the DSM-5 criteria of schizophrenia, and you need to know this, especially criterion A. So we keep harping on about this, but so the criteria for schizophrenia is that delusions, hallucinations, disorganized speech growth, disorganized behavior, and negative symptoms. At least two of the following must be present, and at least for at least 1 month. Okay, so this is representing psychosis. They need to be in psychosis for at least 1 month, and one of the symptoms must be one of the highlighted ones. Okay, that's really important to know. And there's dysfunction in socializing, working, and self care. So their functioning is really drastically impaired. Okay. And the duration of at least 6 months. So this includes the 1 month that criterion A must be present for. And when we talk about 6 months, we're talking about the whole thing. So we're talking about all of this. So prodromal active residual must be for 6 months in order to meet the diagnosis of schizophrenia. And of course, not explained by a better diagnosis. So this is a really nice schematic that sort of helps you visually see what we're talking about here. So if we just walk through the schematic, so this is time on the x-axis and y-axis is health. So this dotted line is the person's basic uh, the basic function or pre-morbid level of health. So they're quite well. And then prodromal, there's a noticeable decline. And then they become psychotic and it can go up and down. And then this one represents the residual phase. So gradually improving positive symptoms and then negative symptoms and function decline may still remain. And then they can reach a stable phase. So this is prodromal. This is the active or psychotic phase, and this is residual. So all of this must be at least 6 months for you to make a diagnosis of schizophrenia. And then just a little bit more on schizophrenia. It's about a 1% lifetime prevalence. The peak onset is different for genders. So people assigned male at birth, the peak onset is late teens to 25. People assigned female at birth is 25 to 35. And then there's a second peak at age 40. Risk factors include family history, low socioeconomic status, substance abuse, childhood trauma. Again, it's as with all psychiatric conditions, it's an environment versus genetic thing. So certain events in life can reduce the threshold for schizophrenia to occur or to be triggered. So this is the prognosis. Most people have multiple episodes with good recovery each. However, about 38 to 40% have unremitting, continuous deteriorating course. So some positive predictive factors is short duration of untreated psychosis. Comprehensive treatment during the first 5 years of illness. The first 5 years is really, really critical. To determining what the rest of the person's disease's natural history is. High premorbid occupational achievement and high premorbid social competence is also a good prognostic factor. If the person's at lower risk of substance misuse, it's a good prognostic factor, and its good insight is really important as well. And then if the person has a sense of self-efficacy or they can take care of themselves, is a good prognostic factor. So for treatment, we won't talk about this too much because you'll have your psych drugs revision lecture as well. So obviously the main thing is antipsychotics, and there's so many of them out there. They each have their own pros and cons, and you can hear more about that in the medications revision lecture. But yeah, we like to talk about treatment for any psych disorder as a biopsychosocial framework. So if you're ever in an OSCE and you get asked what should the treatment be, bring this model out. Talk about one thing from each of these facets, and you will get marks for it. So biological, of course, is medications, antipsychotics. You can also do brain stimulation therapy. So that's your ECT, your TMS. TMS is more seen in the private land. It stands for transmagnetic stimulation. Not really seen in public. And then you have your lifestyle factors as well. So drug cessation, SNAP-W, so smoking cessation, nutrition, alcohol cessation, physical activity, weight loss, and then management of comorbid conditions such as diabetes, heart disease, kidney disease, things like that. So psychoeducation is important for both the patient and the family. So getting them to be more educated on what schizophrenia is and how to recognize the signs, that can be really helpful. And CBT is helpful as well. And cognitive remediation therapy is good for negative symptoms. You don't need to know too much about that, but it's basically sort of getting the brain to be able to learn things again and redoing things. So social, it's important to establish support networks. You can refer them for case management or social worker, and the social worker can set up additional supports if needed, such as the disability pension or housing, and as well as NDIS. That's a whole process in and of itself. So social part is really important. And then encouraging academic and occupational attainment as well can be really helpful, because the positive prognostic factors, if they can be self-sufficient, it is a really good prognostic factor. A brief note on clozapine. You guys will need to know this. I'm sure we'll talk more about it in our medications lecture. So you need to know when clozapine is indicated. So it's indicated for treatment-resistant schizophrenia. So what does that mean? So you need to know that it means the failure to control positive symptoms of schizophrenia during an episode with 2 or more antipsychotics during a period of at least 6 weeks. And you need to make sure that the compliance for these antipsychotics has been good, i.e., the patient has been taking them. So clozapine is a sort of a miracle drug. It's the most effective antipsychotic. It's able to induce remission of symptoms in about 50% of these treatment-resistant people with schizophrenia, but it has really bad side effects. So side effects include weight gain, sedation, nocturia, hypersalivation, labile blood pressure. And the really serious side effects or complications are, you should know these four: myocarditis, agranulocytosis, bowel obstruction, and seizures. And there's a whole heap of things and investigations you need to do before you can administer clozapine, and the patients need to go on a clozapine register. I won't go through that today. So then we have schizophreniform disorder. So it is basically the same thing as schizophrenia, but it's shorter. So schizophrenia, remember we said the whole thing, so the prodromal, the active, the residual phase has to be over 6 months. Schizophreniform is between 1 to 6 months. So it's less in duration. You'll notice that it has the criterion A is the same as the criterion A for schizophrenia. Okay, and their daily function is impacted. Okay, and it needs to be duration of at least 1 month, including 1 month of this, and positive prodromal active residual symptoms is all between 1 to 6 months and not explained by a better diagnosis. So this sort of spectrum is really important for you to memorize. So schizophreniform is 1 to 6. Schizophrenia is more than 6 months. And that brings me to brief psychotic disorder. So that's an R3. So it's basically the same as schizophrenia, but shorter. It's under a month. Okay, and the criterion A is slightly different. Must have at least one of the following. So instead of 2, and one must be delusions, hallucinations, disorganized speech, and it's a duration of 1 day to a month, and eventually returning to a previous level of functioning. Okay, and it's not better explained by a better diagnosis. It's not the person hasn't taken drugs or anything. So it's important to know this one. So what you need to remember is brief psychotic episode or disorder, less than 1 month for the whole thing. Schizophreniform disorder, 1 to 6 months. Schizophrenia, over 6 months. Memorize that. So let's move on to schizoaffective disorder. So it's an R2. We'll just talk about the DSM-5. So it's an uninterrupted period of illness, which there is a major mood episode. So it has to meet the criteria for a major depressive episode or a manic episode, and it's concurrent with criterion A of schizophrenia. So the person is in psychosis and also is depressed or manic, is basically summing that up. And then criterion B, delusions or hallucinations for 2 or more weeks in the absence of major mood episode. So they must not be an active depressive disorder or active mania, and they for at least 2 weeks while they're having delusions or hallucinations. And symptoms that meet the criteria for a major mood disorder are present for the majority of the total duration of the active and residual portions of the illness, and it's not better explained by a better diagnosis. So as it can be classified into 2 subtypes, so bipolar. So exhibits both manic and depressive episodes, or unipolar, so exhibits only depressive episode. To sum it up, basically, it is like just schizophrenia combined with a mood disorder. Now, the current understanding that we classify it as a psychotic disorder instead of a mood disorder. Um, and the treatment is the same for as schizophrenia, the biopsychosocial thing, but we can add in a mood stabilizer or an antidepressant depending on if it's a bipolar or unipolar subtype. Okay, it's really important to know that antidepressants are really bad for bipolar subtypes, as is the same in BPAD. The next we'll talk about delusional disorders. Oh, delusional disorder. So it's basically the presence of one or more delusions with a duration of 1 month or longer. Um, and criterion A for schizophrenia has never been met. So it means that they don't have disorganized thought or speech. Um, they don't have hallucinations, or if they do have hallucinations, it's related to the delusional theme, and they don't have disorganized behavior. Okay, so you can't call it psychosis because they don't meet those criteria. However, they do have this persistent delusion for more than 1 month. Apart from the impact of the delusion and ramifications, functioning is fine. So not markedly impaired, and behavior is not weird. Okay, so these people, they're able to function fine. They're able to go to work, socialize, go to school, but they just have this delusion that's unshakable. Okay, and then these two aren't that important. So to summarize, the patient has one or more delusions, but it's not in psychosis, and otherwise they function fine. That's what you need to know about delusional disorder. This is an example of a patient I did come across. So the patient was convinced that her parents are running a child trafficking ring, but she's still fine. She has her own family, works, has work. It is fine. Treatment, if the delusion's not affecting them, do they really need an antipsychotic? So, yeah, you can treat it with an antipsychotic, but I guess it depends on the clinical situation, and you won't be asked treatment for delusional disorder, anyways. Well, I always like to bring up Ernest Hemingway. He's a famous writer. Um, Throughout the years of his life, he was convinced that he was being spied on by the FBI. Everyone thought he was delusional, and everyone thought he was crazy. And then after his death, it turns out it was true. The FBI was surveilling him because he was into left-wing ideology, so they thought he had connections to communists. So it did end up being true. So who the point I like to make with this is, how do we really know it's a delusion? So it's always important to consider, what if it is true? Let's talk about substance-induced psychosis. This is a DSM-5, presence of one or more or both of the symptoms, so delusions, hallucinations. There's evidence, so this whole criteria just basically says that they're having these symptoms after they did a substance or took a medication. It's not better explained by something else. This disturbance doesn't occur during the course of a delirium. That's important, and causes clinically significant impairment to daily functioning. So some common culprits for substance-induced psychosis are your cannabis, cocaine, amphetamines, methamphetamines, psychedelics. So this includes LSD, psilocybins, MDMA, ketamine, and of course medications as well, and steroids and Parkinson medications, as I have reiterated before, are really, really bad for this. And that's all you really need to know about substance-induced psychosis, when it comes up on your exams, it'll be pretty obvious. It will say that, well, there should be clues in the question saying that the person has taken drugs or taken medication, and um, should be pretty clear cut. Oh, and the treatment is you can give them an antipsychotic for the duration of psychosis, and stop the drug taking. So psychosis secondary to an organic cause, that's an R3, I think. So causes can be neurological, so stroke, acquired brain injury, CNS infection, and NMDA encephalitis. So it's an autoimmune disease where it attacks your brain, MS, Parkinson's. It can be metabolic or endocrine, so thyroid, adrenal, electrolyte, B12 thiamine. Investigations basically just look for the cause. It's quite low yield, so I won't touch on it too much. The treatment is you treat the medical condition that's causing this, and then antipsychotics if needed. So on this slide, I have high yield things that you need to remember. You need to remember this continuum. Brief psychotic disorder is less than 1 month. Schizophreniform disorder, 1 to 6 months. Schizophrenia, more than 6 months. Just need to remember that. Time is off. The timeline of things is really important in psychiatry. Delusional disorder does not meet, it's important to know that the person does not meet the criteria for psychosis and the person functions fine. That's your biggest clue. They function fine. Schizoaffective disorder, as we said before, meets the criteria for psychosis and a mood disorder, so mania or depression. So use your dig fast or Siggy caps, see if they fulfill that. Delusions and hallucinations must be present for at least 2 weeks without a mood disorder. Substance-induced psychosis, they have done drugs or took a medication. It's that simple. Psychosis due to an organic cause, the question will usually give you clues. You need to pick up on it. I like to think that nothing is wasted space in a question. If the question says something, they want to give you a hint about something. So always try and pick up on what that hint is. And I thought it would be important to pop in a delirium. A lot of the time, or a lot of the exam questions are often trying to get you to differentiate between delirium and psychosis. So it's important to just remind you guys that delirium is an acute disturbance in attention or awareness. Develops over a short period of time, fluctuates throughout the day, and the most important thing is that the question will usually allude to a medical cause. I popped this slide in because last year there was heaps of exam questions trying to get us to differentiate between whether this person had a psychotic disorder or dementia, and I think it can often be hard because dementia can cause psychosis, and psychosis can cause cognitive effects. So the cognitive symptoms that can and the negative symptoms can overlap with that of dementia. So I think it's important to remind you guys that the primary symptoms of psychotic disorders are delusions and hallucinations, and the primary symptoms of dementia is loss of cognitive function, so memory loss, loss of executive functioning, etc. The onset can be quite sudden for psychotic disorders and is usually quite gradual for dementia and keeps getting worse. They don't tend to get better. Psychotic disorders, they can get better. Age of onset as well, although psychotic disorders can present later in life as well, but usually if it's a young person, it's more likely to be a psychotic disorder, and dementias are usually later in life, although frontotemporal can present quite a bit earlier. You should really know your types of dementia as well, and I'm sure they'll be covered really well in our aged psychiatry revision lecture as well. So lastly, I thought we should go through some practice questions. So feel free to pause and think through each question. Okay. So you can pause now. and then pick your answers. So the answer to the first one, Mark, is that it's an idea of reference. He thinks that the TV are sending hateful messages about them in all their shows, so that's an idea of reference. Um, Rob, he thinks he's best in the business. No one else can do what he does. That's a grandiose delusion. So hopefully, pretty straight cut. So again, feel free to pause. So yeah, this one is talking about hallucinations. So skin is crawling, formication. So we talked about that. So it's a tactile hallucination. Effie, this is an illusion. So the difference between an illusion and a hallucination is that illusions it's quite plausible for someone to mistake seeing something. So thinking the fire hydrant is like a small child, that's or the post box is a person, and then you get closer and you realize it's not. That's not a hallucination. That's just an illusion. So I thought that was important to keep that to bring this point up. Okay. So have a pause again. Okay, so this one, the answer is schizophrenia. And the important things to uh, take out of this question, whose logic is very difficult to follow. So that means she's got thought disorder. Appears to be concerned that Malcolm Turnbull has been possessed by an alien life form, so it's a delusion. Okay, so that's already fulfilling two of the criteria of criterion A of schizophrenia. Um, and the other important thing is that she dropped out of uni for no apparent reason 7 months ago. So this timeline is really important. So it's more than 6 months. So um, she fits the diagnosis for schizophrenia. Okay, feel free to pause again. All right. So here are the clues in the question. He cannot explain himself very well. So sort of thought disordered, but seems to be very concerned about how and where people shop for about 6 months, 6 weeks now. Delusions. Um, and then the most important thing, the change has been about 3 months. So it's between 1 to 6 months. So this is schizophreniform disorder. Okay. Feel free to pause again. All right, so this one is delusional disorder. Um, this one, it's a bit tricky because the question does say he's unemployed, but I think the rest of the question, his mood, affect are fine, thought form is normal. He doesn't fulfill the criteria for criterion A in schizophrenia, and he doesn't have hallucinations or isn't using drugs. So uh, and his wife is confirming that this is consistent with how he usually acts, so it's a delusional disorder. Pause again. All right, so hopefully you picked up that feeling anxious, more energetic, weight loss are signs of hypothyroidism, and it's important to rule that out first. So we've picked thyroid function tests. In a real sort of situation, you do pretty much most of these. Um, but yeah. So the answer to this one is amphetamine-induced psychotic disorder. So this one's a bit tricky, because um, it didn't really say that he took drugs, but you can sort of assume. So he was at a party the previous night, um, and the onset is quite sudden. Um, and the hint that it was amphetamine-induced psychotic disorder is here. So he's sweating a lot. Um, so you typically see that with amphetamine use, like that sort of sweaty, anxious mess. So that's why that is the correct answer. So the answer for this one is delusional disorder. So the clues in this question is that the man works part-time as a pharmacist, so he's working, he's functioning fine. This belief is longer than 1 month. It's for a number of years. That he is concerned about the computer system, um, and then the fact that he continues to complete his work effectively and he's functioning fine. So that is delusional disorder. So again, this is referential delusion, so something that has completely nothing to do with Chris. He thinks that it's about him, that he received a signal from the black clothing on the mannequin. All right, we'll click through the answer soon. So this one's a bit more difficult. So pat yourself on the back if you've got this. So it is delirium. So this is because she's 23, so um, she is in the right age range for a psychotic disorder. However, the question alludes that she's had a flu-like illness, and she's got she's hallucinating, and she's struggling to follow the conversation, so and forgetting some elements of it. So it's it the delirium is a disturbance in attention and awareness and concentration. So she's having difficulty keeping attention and concentrating. So um, that also alludes to delirium, but because of the flu-like illness, it is the answer is delirium. So that's all for the lecture today. Thank you guys for coming. Good luck with your exams, and here's my email again if you'd like to send me any questions. I will leave by just saying that the psychiatry exam is really quite easy. You'll um, most of the time the answers are quite clear cut, and it's just whether it's like saying um, it's like the questions we went through, then hopefully they weren't too hard, and everyone passes the psych exam pretty well. So good luck, and have a good rest of the day.